Welcome to this exam preparation video focusing on the short case of Xeroderma Pigmentosum. This video is divided into two parts: clinical performance and examiner Viva questions, both essential for your success at the examination center. Part 1 is dedicated to clinical performance, guiding you on how to present at the bedside. We will cover the examiner's command, lesion description of the face and tongue, relevant examination steps, and differential diagnoses.
Examine the face and do relevant examination. Mention Sanctis-Cacchione Syndrome. Notice, the examiner has specifically asked you to mention Sanctis-Cacchione Syndrome. This means it must come up either in your examination or your differentials. Do not wait until you are asked. Bring it in yourself. The moment you start, state the general condition first. You say, "My patient is a young male, sitting comfortably on the couch, well cooperative throughout the examination." Then follow this order every time: distribution, type of lesion, surface findings, associated findings. Do not jump to a diagnosis. After lesions, state what else you would like to examine and why. Use the phrase, "I would like to examine."
On cutaneous examination, you say, "There is diffuse involvement of the face, consisting of hyperpigmented macules and few hyperpigmented to deeply pigmented hyperkeratotic papules scattered over the whole face. I can also see fine scaling over the involved areas. The underlying skin is xerotic. I can also appreciate an erythematous atrophic plaque with some areas of crusting and erosions present over the bridge of the nose." Now, the critical finding. On further examination, I can also appreciate a well-demarcated, solitary fungating growth present over the tongue. Then describe its properties precisely. It is approximately 3 by 2 centimeters with well-defined margins. The surface is covered with purulent discharge and slough. It is tender, with a normal temperature gradient and adherent to the underlying structure. This fungating growth changes everything. It tells you the disease has progressed to malignancy. Keep that in your mind when you reach your differentials. After your lesion description, state what you would like to examine. Use this phrase, "I would like to examine." This tells the examiner you understand this is a bedside assessment. I would like to examine the rest of the skin, especially sun-exposed sites, for similar lesions. I would like to perform an ear examination, Rinne and Weber tests. I would like to examine the eyes, checking for corneal erosions, ulcers, and symblepharon, and I would test visual acuity. I would like to examine the oral cavity for erosions, ulcers, or malignancy. I would like to perform a lymph node examination. I would like to examine the scalp for alopecia and microcephaly. I would like to perform a CNS examination, motor and sensory examination, tone, power, and reflexes, and I would check the gait and look for ataxia. I would like to perform a respiratory examination for pulmonary stenosis. I would like to complete a cardiovascular examination and a donatal examination. This systematic list tells the examiner you think in systems.
My differentials include: first, Xeroderma Pigmentosum; second, leopard syndrome; third, XP with malignancy.
Now the examiner will ask you questions. Let me take you through each one precisely, using the exact answers you must give.
The examiner asks, "What is the cause and genetics of XP?" XP is an autosomal recessive inherited disease. The signs and symptoms of XP are the result of impaired nucleotide excision repair system. 2 types of NER have been identified: genome-wide NER and transcription-coupled NER. The examiner then asks, which complementation groups are associated with severely exacerbated sunburns? XPA, B, D, F, and G. The examiner asks, what is XPV? This is the variant of XP which is diagnosed in adulthood, after 30 years, after the patient has already developed multiple skin cancers. The NER pathway is normal, and it is caused by mutations in the POLH gene encoding DNA polymerase. There are no ocular or neurological manifestations in XPV. The examiner asks, what are the stages of XP? XP passes through 3 stages. Stage 1 appears after 6 months.
It is characterized by diffuse erythema, scaling, and freckle-like areas of increased pigmentation over light-exposed areas. Stage 2 is characterized by poikiloderma, which consists of atrophy, telangiectasias, and mottled hyperpigmentation and hypopigmentation. Stage 3, appearance of numerous malignancies, including SCC, BCC, and malignant melanoma.
The examiner asks, how will you confirm the diagnosis of XP? Diagnosis can be confirmed by measurement of unscheduled DNA synthesis in cultured skin fibroblasts, which are established from a 4mm punch biopsy taken from an unexposed area of skin. The fibroblasts are UV irradiated in a petri dish, and UDS can be measured as incorporation of nucleotide into the DNA of the irradiated cell by autoradiography, liquid scintillation counting, or fluorescence assay. A reduced level of UDS confirms the diagnosis. The examiner asks, what are the ocular findings in XP? Know all 8. Photophobia and conjunctivitis, ectropion of the lower eyelid, corneal erosions, corneal opacities, pigmented macules on conjunctiva, pterygium, epithelioma of the cornea, and symblepharon. The examiner asks, what is Sanctis-Cacchione Syndrome? It is characterized by XP with dwarfism, hypogonadism, low intellectuality, and ataxia. 4 features. Memorize them exactly. Do not confuse them with general XP complications.
The examiner asks, what are the complications of XP? Complications include mucocutaneous malignancies, SCC, BCC, and malignant melanoma, solid organ malignancies, meningioma, glioblastoma, medulloblastoma, spinal cord astrocytoma, and schwannoma, and neurodegeneration, low IQ, ataxia, and spasticity. The examiner asks, what is the treatment? Sun avoidance and sun protection, protective clothing, round hats, gloves, UV films on car and home windows. Avoid smoking, vitamin D supplements, retinoids for skin cancer protection, topical imiquimod and 5-FU for early or pre-malignant lesions, artificial tears, and ophthalmology consultation. For emerging treatments, topical DNA repair enzymes such as T4 endonuclease V, gene therapy, research into CRISPR/Cas9, immunotherapy and targeted therapies, drugs like checkpoint inhibitors such as pembrolizumab, and genetic counseling. The examiner asks, what is the prognosis? There is no cure for XP. The overall median age of death is 32 years, with skin cancers and neurodegeneration as the main causes of mortality. In XP without neurological degeneration, the median age of death is 37 years. For those without neurological disease and with rigorous UV protection, prognosis is good. Before you go into that examination room, carry these points with you. XP is autosomal recessive. Defective NER is the core mechanism. The fungating lesion on the tongue means stage 3. Malignant transformation has occurred. XPV has intact NER, POLH gene mutation, no neurological or ocular features, diagnosed after age 30. Sanctis-Cacchione is XP plus dwarfism, hypogonadism, low intellectuality, and ataxia. Confirm with UDS in cultured fibroblasts, biopsy from unexposed skin. Median age of death is 32 years, no cure. At the bedside, always say, I would like to examine and I would like to request. Go in prepared, go in structured.